Cold lasers in pain management. Low energy laser therapy has been shown at appropriate dosimetry, wavelength, duration, and site specific application to reduce tissue pain or tenderness, normalize circulation patterns in tissue trauma, and increase collagen formation in wounds. Cold or soft laser therapy, also known as low level laser therapy, is being used for an increasing number of medical and rehabilitative applications, including pain management. The nomenclature alludes to the athermic or non heat producing characteristic of these FDA Class 2 and Class 3 devices. Unlike hot lasers used to cauterize, vaporize, coagulate, or ablate tissue or tumors, cold lasers work through more subtle tissue effects that can result in the reduction of both pain and inflammation, devoid of tissue destruction. Consequently, cold lasers are finding a niche with soft tissue specialists of varying backgrounds, including medicine, podiatry, dentistry, and physical rehabilitation. Although a relatively new modality in the United States, cold lasers have been used in Canada, Europe, and some parts of Asia for many years. Lasers fall under the general category of photomedicine, but this broader name often obscures the unique properties inherent with laser, properties which serve to distinguish this form of light therapy from other, perhaps less potent forms of light energy. In 2002, the FDA issued the first 510K per pre-market notification for a soft or cold laser device based largely on the strength of earlier large-scale multi-center clinical trials that had examined the effectiveness of cold lasers in the primary treatment of carpal tunnel syndrome. The GM study, as it has been come to known by, was arguably the pivotal investigation that tipped the scale in favor of FDA approval for these devices. Since then, a number of laser manufacturers have followed suit with their versions of ideal lasing device. To date, all these devices have been under specified power level of 1 watt, considered to be threshold for thermal effect, and usually between 5 and 100 milliwatt. As a point of reference, a laser pointer is approximately 2 to 3 milliwatt in power. Recently, FDA Class 4 devices have been introduced into the marketplace with much higher average power levels than their Class 2 and 3 counterparts. Typically seen in veterinary medical use, time will tell how these devices will add clinical utility to the already growing number of lasers in the marketplace. While numerous studies utilizing cold lasers have been performed to date, many do not provide precise test parameters such as power density, treatment duration, wavelength, and site of application, all essential information needed to replicate findings. Despite the currently limited amount of quality research supporting cold lasers use, the number of double-blinded, randomized, and controlled trials is growing, as well as the amount of empirical evidence gathered from the now daily use of these instruments across the country. Laser tissue interaction. The two most important modes of light interaction with tissue during laser treatment is through absorption and scattering. This has been studied predominantly at the molecular and macromolecular level. Absorption is considered to be conversion of energy from light to another form. Tissue absorbing properties are dependent on their concentration of light accepting molecules such as amino acids, cytochromes, chromophores, and water. Each of these interacts with light at specific wavelength ranges, Scattering also during cold laser treatment is considered to be a change in light propagation direction and thought to occur due to varying shapes of biomolecules and varying tissue interface configurations. Depth of penetration determined by tissue type and wavelength emitted by a laser system. Like other forms of energy used in clinical settings, such as electricity, heat, and sound, there is significant energy attenuation of laser light as it passes through tissues. The critical measurement in laser dosimetry appears to be energy density, which is calculated by dividing the total energy delivered to an area by the area of irradiation and expressed as joules per centimeter squared. Among other lasing characteristics, the energy density should always be reported in clinical studies so replication is possible. The general consensus among clinical clinicians using low level laser therapy for conditions having an inflammatory component is that significant benefits can be occurred by those patients treated with laser. Animal studies have typically cited radiant exposure levels of 3 to 4 joule per centimeter squared, whereas in human studies it is recommended that significantly higher levels of irradiation, approximating 30 joules per centimeter, are required to compensate for animal size and skin type differences. Clinical application of low level laser therapy. Arthritis. The arthritides, osteo and rheumatoid forms have been a popular target disorder for researchers in the last decade of cold laser investigation. The results of several well designed randomized clinical trials have given clinicians good reason to be encouraged with this form of treatment. Cellular research has provided some possible mechanisms of action for these positive results, including laser mediated increases in cellular proliferation, enhanced collagen synthesis, conversion of fibroblasts into myofibroblasts, increased osteoclastic activity, reduced inflammatory markers, increased lymphocyte response, and stimulation of the electron transport system, leading to enhanced ATP production. These putative mechanisms help explain the impressive results that laser therapy research has had to date in the area of wound healing. Probes emitting beams of mixed wavelength, clinicians can efficiently treat large wounds in short period of time. Grosso et al. Conducted a systematic review of the available literature examining the relationship between low-level laser and arthritis in 2000. They applied an priori protocol according to the methods recommended by the Cochrane collaboration. Their conclusions were that low-level laser therapy should be considered for short-term relief of pain and morning stiffness in rheumatoid arthritis. In regards to osteoarthritis, the same authors felt that a determination of effectiveness could not be made based on the available literature due to conflicting and lacking consistent dosage descriptors. General consensus among clinicians using LLT was for conditions having an inflammatory component is that significant benefits can be occurred by those patients treated with laser. There have been very promising clinical trial involving cold laser in both knee and cervical spine, arthritis, osteoarthritis as well. Carpal tunnel syndrome, although not as studied a clinical condition as other allergies, this landmark cold laser in investigation occurred at the Flint. Michigan GM plant when Anderson et al. Studied the effects of cold laser on carpal tunnel syndrome. In this particular study involving 119 subjects, half received sham laser plus physical therapy, while the treatment group received a real laser plus physical therapy. The results of this randomized controlled and double blinded study were that there was statistically significant treatment effect shown by real laser group. Furthermore, the author stated that low level laser therapy combined with physical therapy, strengthening ROM, etc., improves functional measures of wrist hand work performance and results in greater probability of return to work. Since that study was completed, others have followed the similar configuration confirmations of laser potential efficacy in the treatment of this insidious and economically costly occupational disease known as carpal tunnel syndrome. Dosages described by various investigators range from 2 to 10 joules of energy per point per treatment session, with several key points usually comprising the total treatment area. As an example, Weintraub reports using 9 joules of energy over 5 points per session, with a treatment course ranging from 7 to 15 sessions depending on individual patient response. Worms et al. Applied a 5 joule per centimeter squared energy density dosage scheduled to their patient sample number 33 and found beneficial results as measured by sensory distal latency on EMG. Myofascial pain and trigger points. The application of cold laser to myofascial syndrome is very common among photobiology specialists. These seemingly innocuous but sometimes debilitating, tender, and painful areas can be a cause for concern for many patients. There have been numerous therapies and treatments expounded for their TP eradication properties stemming from pharmacotherapy and injections to acupuncture and positional release techniques. Numerous studies have supported the benefits of cold laser application for musculoskeletal pain and dysfunction caused by trigger points, a common source of localized myalgic pain. Lasco et al. Published a randomized, double-blinded, placebo-controlled clinical trial involving 41 patients with confirmed trigger points in the upper extremities. His treatment regimen included each subject receiving 5 treatment sessions twice daily using both a near-infrared 670 nanometer of 10 milliwatt average power and a far-infrared unit 820 nanometer of 25 milliwatt average power level. A total of 1 and 5 joule per centimeter square, respectively, were used by these investigators. Their results supported a positive treatment response with both wavelengths. However, the 820 nanometer laser provided the greatest treatment effect. Simonovic et al. Studied 243 subjects with confirmed trigger points and found very similar results with pain, tenderness, local muscle tautness, and amount of required pain medications, all reducing significantly in his patient population sample. They used virtually identical wavelengths as Lasko et al., including a helium 632.8 nanometer and an infrared 820 nanometer unit. They found that pain decreased by over 70% and concluded by endorsing LLT as their an effective monotherapy and a very important adjunct. These findings simply confirmed what was originally found in 1986 when one of the first studies examining the effectiveness of LLT on the trigger point phenomenon appeared in the Journal of Physical Therapy. Senator Markle et al. Reported that LLT, even at what is recognized today as being at a very low dosage was effective in reducing pain and tenderness in their small sample group. This group of investigators utilized a relatively low-powered helium neon laser with supposed minimal penetration capabilities, and what we know today is optimally designed for more superficial scanning such as in decubitus ulcers and or post-injury tissue necrosis. Subsequent studies seem to support the idea that the laser therapy not only reduces pain or tenderness but may also act to normalize disrupted circulation patterns inherent in tissue trauma. Several studies have alluded to a noticeable temperature adjusting mechanism when low level laser therapy has been used. In acute conditions, Asagai et al. Noted that there was a noticeable cooling effect in the hot zone of an injury post-laser application where inflammation was most pronounced. In contrast, the peripheral zone, an injury which is typically of lower temperature during inflammation, was seen to gradually rise by same amount as the hot zone dropped, approximately 3 degrees Celsius post lasing. The author the authors noted that consistent with these vascular changes confirmed by thermography, there was concurrent reduction in clinical signs of swelling or edema as well. In the treatment of chronic pain, Fukushi et al. Using a higher power GaAs semiconductor laser with output of 100 milliwatt at a wavelength of 810 nanometer found that skin temperature rose significantly in the treatment group and not at all in this sham control group. Furthermore, 75% of the treatment group demonstrated improvement in pain and tenderness level while only 4% of the control group improved. An increase in tissue temperature is an unusual finding given that soft or cold lasers are named as such for their non-thermal effects. These positive outcome results are similar to those of Selansky et al., who also showed that when laser was added to a treatment regimen consisting of therapeutic exercise and spinal adjustments for treatment of whiplash injury, the therapeutic results are superior than treatment consisting of exercise and spinal adjustment alone. There are three essential components to a laser system, those being a lasing medium, an energy source, and the mechanical structure of the laser. We will continue this discussion to cold lasers in the near to far infrared range of electromagnetic spectra, visible to red to invisible red. The lasing medium is a material which is capable of being excited by an outside source and absorbing that energy produced when electrons are excited from one level to another. Lasing media can be gaseous, liquid, solid, crystal, or semiconductor in nature. Helium neon is an example of a gas medium laser, while gallium aluminium arsenide is an example of semiconductor medium laser. The selection of the lasing medium is important since this will dictate the wavelength of the device's output and ultimately determine the color of the beam and depth of penetration. Description, however, invariably the energy source most common to systems used in pain management will be electrical power. Lasers operating in the 632 visible red to 1000 nanometer far infrared wavelength and used to treat pain and myofascial syndromes will typically be driven by local main power supply. Early therapeutic lasers utilized two wavelength specific mirrors mounted parallel to each other and a fixed distance from each other, multiple of the laser's wavelength, so as to reflect only a certain wavelength range. This mechanical structure holds true today for many lasers except those using semiconductor technology. These units are polished diodes and special lenses to both selectively emit and concentrate the laser beam consisting of light particles or photons. Laser light distinguishes itself from other forms of light in that it is monochromatic, directional, and coherent. The spectral emission bandwidth from a laser is much more limited than other sources of light, such as incandescent or fluorescent light. Lasers emit at specific wavelengths such as 632 nanometer, whereas comparison and infrared lamp emits many wavelengths within the infrared spectral range. This becomes important as wavelength becomes the primary determinant of depth of penetration. The term collimation refers to a laser's high degree of beam parallelity and is the opposite of beam divergence. This becomes clinically important since the greater the divergence, the larger the spot size for treatment and the lower the power density. A more focused beam increase the power density and also increase the ocular hazard for both operator and patient. To minimize losses in power, and the laser should be kept as close to the target tissue as possible. It is important to note that neon laser sources of light scatter light at many wavelengths in different directions. In stark contrast to laser light, which is focused almost perfectly parallel and in one direction. Finally, a laser is said to have coherence, a property whose biological significance has been debated by researchers. Coherence suggests a synchronicity in light waves so that each wave maintains a precise spatial relationship with other waves and that this pattern is maintained over long distances. Having said this, there is a trend towards manufacturing superluminous diodes which are highly monochromatic and collimated but not coherent sources of light. This translates to a less expensive and cheaper manufacturing process while retaining many of the true laser